Good morning, ladies and gentlemen, and thank you to the organisers for inviting me. I got involved, I think, with this at a fairly early stage. Jonathan, who I'd known for some time, invited me to come and discuss with a group about the potential clinical benefits of Sergi honey. And for the first time, I met the Staples team and a number of other colleagues who are here today. And I was intrigued that this could possibly become a remarkable innovation for the management of a whole variety of infections. And I also, rather like Jonathan, came at it from an antimicrobial resistance point of view, because being a clinical microbiologist, I'm acutely aware of the massive global problems of antibiotic resistance, largely driven by inappropriate antibiotic use around the world, and resulting in a global crisis which we haven't really found the solutions for. I could see its potential in wound infections, and I'll discuss that quite a bit, but I think there are a lot of other ramifications that we can use Sergi honey for. And I think any of us practicing medicine today really in fact, most of us in the world today cannot remember a time before antibiotics. We've kind of forgotten the advantages that we've had as a couple of generations of both vaccination and antibiotics in terms of controlling antibiotic resistance. You see this picture here. This is a family portrait, probably the only family portrait of this Victorian family of 3 children, but you'll notice that 2 are in black and slightly blurred because they can't keep still long enough for the exposure, but the only one in focus is the dead child on the bed, dressed in white, who almost certainly died of an infectious disease because there was no specific treatment. And yet we now have an impending global crisis which nobody can really take terribly seriously yet. I know there's lots of press about it, but it really is, at the moment, an unsolvable problem. And if you look at these arrows, the width of these arrows as being the strength of the process, it's driven by a thick arrow because we use too many antibiotics. We have thick arrows for selection pressure on bacteria because we're a crowded planet using lots of antibiotics. We have intensive livestock rearing. We have generally in the world poor public health with human bacteria being spewed into the environment. Also in the world, we have generally poor public health and poor infection prevention, hence a narrow arrow. And we have relatively few new antimicrobial agents being developed. The solutions are logical. We just need to switch the width of all those arrows, but achieving that is very, very difficult. There are very few new antibiotics coming along. Now, the big pharma companies might say otherwise, but most of the new antibiotics are sons or cousins of existing agents. There are very few, virtually no new classes or new innovative ways of killing bacteria. What's more, as I've mentioned, we have poor public health, and I'm going to give India a hard time here, but they're not the only country. But there are factories making generic antibiotics in India that are leaching antibiotics into the environment. They go into the river system. Further downstream, you've got raw, untreated sewage mixing up in a wonderful sort of primeval soup of low-concentration antibiotics and human bacteria, ideally creating resistance. Further downstream, people are drinking it. So they're getting colonized with multi-resistant bacteria, which when they then go on to develop a clinical infection, can be almost impossible to treat. And because we're a global village now, everybody travels around the world, tourists going to those areas pick up resistant bugs, migrants traveling to other parts of the globe take their bugs with them. And Peter Hawkey, a professor of microbiology in this city, has done some very interesting work around carriage of multi-resistant bacteria. And people from the Indian subcontinent have a 50% chance of carrying in their gut multi-resistant gram-negative organisms compared to, say, about 5 to 10% in the indigenous population. So, but it's all going to equilibrate in time as we all acquire these things. As I've said, the solutions to antibiotic resistance are actually pretty logical and pretty simple, but logistically they're very hard to achieve. We need to use fewer antibiotics, so we need better stewardship to reduce the selection pressure on antibiotics. We need good public health and infection control. That would result in fewer infections and less need to actually use antibiotics. We need better and more rapid diagnostics, and that would require less guesswork in terms of treating patients, because we know what to treat. We need to reinvigorate antibiotic discovery, and that's sort of happening, but in a kind of half-hearted way. And we need antibiotic alternatives, which is the subject of our symposium today. There are various researchers working on a variety of different antibiotic alternatives. And I'm not going to discuss any of these in details, but these are some of those. Bacteriophages, spelt wrongly, but these are viruses that attack bacteria. Probiotics, nice bacteria that you can swallow and compete with nasty bacteria in your gut. Antibiotic-resistant breaker molecules. These are existing pharmaceutical agents that may work with antibiotics to help potentiate the pharmacokinetics and pharmacodynamics that Jonathan was talking about. Bioelectronics sounds a bit wacky, but electrical treatment was used prior to antibiotics, and there may be some clinical use in that. And then reactive oxygen that we're talking about in this symposium. And of course, as we've heard, it comes from honey, and honey's been used for millennia for antibacterial properties and for treating wounds, and it has a variety of different mechanisms, of which probably the most important antimicrobial one is the reactive oxygen, as Jonathan has told us. So I can see this as a solution in a variety of clinical areas because it is very antimicrobial, it's pretty non-toxic, it's and in the form of honey, and I suspect, as we shall hear in the course of today, in other delivery mechanisms, you can get sustained release of reactive oxygen, which can be delivered over a prolonged period of time to help control an infection. Now, I have virtually no claims to fame, but one of them, I think, probably will be that I was one of the first clinicians, if not the first clinician, to use Sergi honey in the clinical environment. And where I see it working particularly well, and there are just, huge potentials for this sorts of treatment, is in inflammation and infection where antibiotics don't work very well. And those are very common situations. They're situations where you have a high bacterial bioburden and you have biofilm. So the obvious clinical situation is chronic wounds, burns, ulcers, and wound infection prevention. But there are many other clinical conditions, as we're going to hear about today, where you also get a lot of bacteria, where you get biofilm, and it's very hard for the antibiotics to penetrate and actually clear those bacteria. So things in the upper respiratory tract, the ear and the sinuses, in the respiratory tubes, in chronic obstructive pulmonary disease, cystic fibrosis, bronchiectasis. We're also seeing an increasing problem with people with recurrent urinary tract infections for which there is no effective antibiotic because of global antibiotic resistance. And I think there's significant potential there. And then there are a whole lot of prosthetic devices, as you can see on the left of this chart, where, again, reactive technology may be helpful clinically. All of these encompass a massive disease burden in the world. So reactive oxygen as an alternative to systemic antibiotics, I believe, has a huge role to play in the future. Now, as I say, when I was first introduced to Sergi honey, Ian Staples presented this trick to me, and he's done it to many people, and it really is a very impressive visual example of how Sergi honey and reactive oxygen work so well. We had a variety of medical honeys that are licensed for wound care. We have Sergi honey here, and we have a hydrogen peroxide stick, which you dampen with a little bit of water for each of these, and then apply to the honey. And you can see that the only one that's gone very bright blue is the Sergi honey one because of the concentration of hydrogen peroxide and reactive oxygen species that are being released, in comparison to no reaction really with any of the other medical honeys. Although some microbiology had already been done by the Irish group in Sligo, Sergi honey had never really been tested against human pathogens in a medical microbiology laboratory. So we did an extensive testing program looking at MIC, the minimum inhibitory concentration, and the killing effect, how swiftly reactive oxygen could kill different bacteria, against a range of pathogens isolated from humans. And for those of you who have any bacteriological knowledge, there are two big groups: gram-positives, which are the staph and streps, and gram-negatives, which are the E. coli gutty light bugs and Pseudomonas. So the whole range of different organisms. And you can see here by this disc diffusion test, you can see the little hole in the center of the agar plate. That's where the honeys were put. So a little bit of liquefied honey with a bit of water to activate it. And we've got the strongest strength of Manuka at the top here. we've got another honey that's not very antibacterial, and Sergi honey down here. And the reactive oxygen is diffused through the agar, and where you've got a zone of inhibition, that's the effect of the honey on that particular bacterium, which in this case is Staph aureus, a common wound infecting organism. And you can see here for Sergi honey, there's a huge, huge zone of inhibition, much larger than for the stronger strength of Manuka honey, and clearly much larger than the inactive honey. And we tested that, as I say, against a range of different human pathogens. So at the top here, we've got E. coli. There you can see Medi honey. And these are different strengths of Sergi honey. This is MRSA, the resistant Staph aureus, Pseudomonas aeruginosa, and Group A strep, which is a nasty bug that causes soft tissue infection. At the same time, we did a little bit of work, but much more research needs to be done in this area. And we'll hear some of this later on today, and certainly in terms of its antifungal activity. But we did some initial experiments looking to see whether reactive oxygen was effective against viruses and against fungi. And some antiviral assays were done in Colindale, the Central Virus Reference Lab, and Manchester University, and these showed activity in cell culture against herpes simplex virus, and antifungal assays have been done as well against yeast like Candida, Aspergillus, and a whole variety of other pathogenic fungi. And we'll hear more about that later in the day. Another experiment we did, which we published in that first paper, was to look at how fast Sergi honey killed bacteria. And we used a broth static culture of Staph aureus, so at room temperature, the sort of organism not growing terribly fast that you find in a chronic wound. And you can see that the control group, there's not much increase in the amount of bacteria because it's in a kind of steady state. We treated it with Manuka honey, which is antibacterial, and it kills off the bacteria eventually after 3 or 4 days. And these are two strengths of Sergi honey. In Jonathan's slides, he called them prototypes. I've just labelled these S1 and S3. But you can see the strongest prototype almost kills the Staph aureus instantaneously and maintains that killing throughout a prolonged period of time without further dosing. And a slightly slower kill for the least potent prototype, but very effective at killing. We'll hear today about experiments done in Birmingham University and in Southampton on its effect on biofilm. So I'm not going to talk any more about this, but this is a slide of Fenella Halstead's, and she's shown that it has activity not only in killing the bacteria, but in reducing this biofilm as well. So we'll hear more about that later on. So that was the in vitro work we initially did. We then went on to say, well, does it work in real patients? So that was the next step, and it was a licensed product, so we felt able to do that. And I thought about the different conditions that we might try testing these in, and I found a number of collaborators. Some of you are here today, and we tried it in a number of centres, both in hospital and in primary care, for the treatment of chronic wounds. And these are the kind of conditions we included. Some of these, of course, were also done in the developing world. We had junior doctor teams going out to remote areas in developing countries, and they took some Sergi honey with them and looked at its effect there on chronic wounds as well. So a variety of centres, both in this country and and abroad. And this is one of the first patients we had, who was an elderly lady, 91-year-old, independently mobile, lived with her nephew, had a good quality of life, but was suffering from chronic, persistent, painful leg ulcers. And she was admitted to hospital for control of these. She received no systemic antibiotics. She just had topical Sergi honey treatment. And you can see after a couple of weeks, the wound is looking much less sloughy, much less inflamed, and with a much lower bacterial load as well. And of course, it occurred to me that this all could have been managed in the community with using reactive oxygen technology without a hospital admission at all, which would be much more pleasant for the patient. Another patient that we had in this same series, and this was a vascular patient, so poor blood flow to the leg, and the patient presented with a very difficult, heavily colonized ulcer, which was also an infection control risk because it was heavily colonized with multiply resistant bacteria, MRSA, vancomycin-resistant enterococci, coliforms and pseudomonas, all of which can spread in the hospital environment and cause infection control issues. My vascular surgeon colleagues were very keen to treat him with systemic antibiotics, but we held off those because he wasn't systemically particularly unwell, and we just used topical Sergi honey. You can see the green pigment in the ischemic ulcer, and that becomes more pronounced as the Sergi honey treatment takes effect by day 4. It's upsetting the bacteria there, and they're releasing more of their pigment because they're being hit by the reactive oxygen. But you can see by day 10, this ulcer is now entirely clear, virtually free. It's not sterile, but it's free of the large proportion of the bacterial load, presenting a much lower infection control risk because all these bacteria have gone. And the ulcer is looking much healthier, nice granulation tissue that can then heal of its own accord. And so that was avoiding a complex and extensive treatment with systemic antibiotics. So we've just finally published this theories. It's come out in the Journal of Wound Care this year. But these were the numbers of patients we had in each of these different categories. You can see their average age there. Many of these wounds had been there for a long period, for many months. And many of these patients had multiple comorbidities as well. They were sick patients. Almost universally, there was, where we did microbiology, there was a reduction in the bacterial load. So we did semi-quantitative microbiology on all these wounds on several successive days. And almost universally, where we had it, we reduced the bacterial load. In many of these wounds, there was evidence of wound healing in the course of the treatment as well, as measured by a reduction in wound size. There was also an improvement in the criteria of localized inflammation, so discharge, slough, and localized inflammation as well. And you can see that the treatment days was quite prolonged, but of course that's very easy to do with Sergi honey. You just put the Sergi honey in every time the dressing is changed. So we then went on to, as Jonathan's already showed some of these slides, but to look at its infection prevention role. And we had a problem in our oncology unit because they've been using topical dressings on the long lines with silver in. And many of the patients had complained about skin staining of the silver dressings, and so they'd stopped using any antimicrobial dressings at all and found they were getting an increased amount of colonization of the line sites. So we used an improvised, locally improvised Sergi honey dressing, so a bit of Sergi honey at the line site with a gauze dressing over the top, and this clearly showed a reduction not only in new colonization of bacteria at the site, but it also cleared bacteria from those line sites as well. We had 1 or 2 patients in the course of this who had multi-drug resistant bacteria. This was a patient who'd come back, who'd been traveling in India with their oncology long line, and it had got colonized with this carbapenemase producing E. coli. And this was cleared at the line site with reactive oxygen treatment. So that was tremendous from the infection prevention point of view. We also had a few cases of patients who didn't have overt surgical wound infections, but had a problem going on. So this is a neonatal, small baby who's had a big abdominal operation at a tertiary centre, and you can see a bit of granulomatous activity at the edge of the wound there, a bit of oozing, and MRSA was isolated from that wound. So again, the paediatricians were very keen to leap in with systemic antibiotics, but in fact this was all treated with Sergi honey, the MRSA was cleared, and the wound healed very well. So again, avoiding complex antibiotics. We treated outpatient or primary care and outpatients. And this is a young lady who acquired, got a lot of ear piercings while she was in Cambodia, and then got these colonized with a community strain of MRSA that was highly toxigenic. It produced something called Panton-Valentine leukocidin. So she had recurrent impetiginous type infections around her face and her ears, all treated with topical Sergi honey and persuading her to take her earrings out as well. That all helped settle the inflammation down. And outpatients within the hospital, this is a young lady who was run over by a tractor and had a very nasty open fracture of her leg. And while the bone was all pin and plated together, the soft tissue was quite excoriated and got heavily colonized with gram-negative organisms and anaerobes and was smelly and unpleasant. And there was also the danger, because of all these pins going into the bone, of infection spreading deeper down into the bone and causing osteomyelitis. Now, Sergi honey cleared all the bacteria from this surface, and it looks much less inflamed and much less angry a few days later. And we prevented deep-seated infection as well. So I think reactive oxygen Sergi honey has all the ideal attributes of a wound treatment, an antimicrobial wound dressing. We know it's antimicrobial. It acts as a local wound barrier. It's non-toxic. We had, I didn't mention it, we had very few adverse events in our series of 114 wounds. We had a couple of patients complained of stinging, but that was literally the extent of the adverse effects. It probably promotes wound healing along with the mechanisms that Jonathan's described. It certainly acts as a wound barrier. It acts as moisture control. It's very effective at de-sloughing and odor control because it kills off the bacteria that produce the smell. And for many patients seems to be an effective pain suppressant. So it has all the attributes I think you'd want of any wound care agent. We then went on to looking to see whether we could prevent infection in surgical wounds. And Jonathan came up with a very bright idea of trying it out in caesarean wounds, because there you've got a surgical wound in otherwise fit and healthy young ladies with very few comorbidities. And yet there is a surprisingly high rate of surgical site infection with caesarean wounds. And we did a before and after study, because this was a pilot study really we knew our infection rate from the infection control team, and it was in the mid-national range for caesarean wounds. And we measured that for 3 months, and then we used Sergi honey for 3 months and measured the infection rate. Now, obviously that's slightly biased, because Sergi honey was taken up with great enthusiasm by the patients, by the midwives, by us monitoring it. So there's a certain amount of bias in that before and after analysis. But in that process, we reduced the infection rate by a staggering 60%. Now, you could say, well, we were paying more attention to the wounds afterwards. Perhaps we were. But nevertheless, I think to show that level of wound reduction is a very striking finding. And, of course, that needs to lead on to a randomized controlled trial, which we're hoping to develop in the future. We've tried treating some fungal infections as well, and this is my one great success in fungal treatment, and this is a young child with a fungal keryon in our pediatric outpatients who refused to take any oral antifungal treatment. We did skin scrapings of that lesion, and he had trichophyton tonsurans, which is shown here. Rather good name, tonsurans, because he had a tonsure of loss of hair from his fungal infection, and we treated him only with daily Sergi honey. And this is the process. Being a fungus, of course, often these are within the hair follicles, so it's quite hard to get topical treatment to penetrate. But nevertheless, in his case, you can see the slow, and it's not that slow for a fungal infection, I can tell you, it's pretty rapid, the slow resolution, and by, I think he had about 35 days of treatment, and he's been fine ever since. We've also tried occasional cases with using Sergi honey to treat viral infections, and these are just 2 examples. I mentioned it has antiviral activity, and in this one experiment, in one patient, I did daily polymerase chain reaction tests of a cold sore. So we had a cold sore with positive herpes simplex virus 1, treated topically with Sergi honey, and it was PCR negative by day 4. Similarly, and of course these are both open to criticism because they're single cases and all sorts of other factors could be involved, but a case of a proven influenza A but vaccinated person, so they were vaccinated and they had throat carriage, PCR positive, and gargles with Sergi honey 4 times a day. The patient was PCR negative by the 2nd day. Now, you could say, well, of course, that was all the IgA immunoglobulin from the vaccine killing off the virus, and it may well have been that. But it's just an interesting observation that clearly needs further investigation. We have some orthopedic colleagues who've tried deep-seated presentation of Sergi honey in complex infected joint renewal, and you can see here the Sergi honey coating the knee prosthesis, and They were keen to do this again to see if there were any adverse effects, and they haven't found any adverse effects, and they haven't really assessed yet how effective it's been in preventing future infection on prosthesis, but nevertheless it seems to be an acceptable process to do from the medical point of view. And I have a great interest in trying it out in chronic cystitis, chronic recurrent cystitis, because we are seeing an increasing number of patients with multi-drug resistant urinary tract infections that are becoming impossible to eradicate with conventional antibiotics. And it's my belief that there is a form of sort of biofilm on the uroepithelium that I think ought to respond very well to reactive oxygen. Again, we need to think about the delivery mechanism for this, how we actually get reactive oxygen to coat the bladder, but also I think we need to do some in vitro work as well. And some of my urology colleagues, both in Winchester and in Southampton, are keen to look at this. So in summary, I think reactive oxygen really is a significant medical development. It has wide antibacterial and possibly antiviral and antifungal properties, tested in vitro in a number of different sites, confirmed in a number of different sites. We've already developed a pharmaceutical-grade wound product. It has a role in infection prevention and antimicrobial stewardship, which I think is really important for the future. It has the potential for a very wide range of clinical applications, not only of skin, but also deeper mucosal infections and possibly even other deep-seated infections as well. And so I think today we'll hear about the initiation and delivery of a diverse program of different clinical evaluations with highly promising results. So on that note, thank you very much for your attention.